Just to give you the background based on which we put together this session, and this session is straight on the theme. And we found variety of countries already having digital health blueprints and then also strategies, but they are in the PDF and the paper. So one of the thoughts that went about putting this session together is to take the blueprints to action or putting the blueprints to practice. So that's the basis on which the conference theme, if you observe, the conference theme is also on this particular topic. And we will begin our sessions with this opening plenary. And I would like to invite Professor Alan Labrick to the stage, and he will be our moderator. Professor Alan Labrick is the Director of the Department of Digital Health and Innovation at the World Health Organization. And he is, by training, he is an infectious disease and population epidemiologist, and then the founding director for the Johns Hopkins University Global mHealth Initiative. We have known him for many years of his work in mHealth. And then he was awarded the Excellence in International Public Health Practice and Distinguished Alumni Award from the Johns Hopkins University. And then we next have Mr. J. Satyanarayana. He is a career civil servant who has served over 40 years now in the government service. And he held very senior positions in the national level. And he, including the Secretary of Electronics and Information Technology in the Government of India. And he was also the chairman of the committee that oversaw the development of the National Digital Health Blueprint in India. And he's a thought leader in digital transformation. And then he has piloted over 10 policy frameworks and 20 large projects for the country. And then he has chaired the expert committee that designed the National Digital Health Blueprint for Education. And then also, he's the chief advisor for Center for Fourth Industrial Revolution and World Economic Forum. And he's involved with the initiatives in the deployment of emerging technologies in health, agriculture, and education sectors. And he's also a consultant for digital health for the WHO region of Southeast Asia, CIRO. And we will have Pak Setiaji, the Chief of Digital Transformation Unit at the MOH Indonesia, joining us in the panel. Pak Setiaji has been an advisor to the Minister on Health Technology, and whom we met this morning on digital health transformation since 2021. And prior to that, he was the head of communication and informatic agency in West Java provincial government. And then also, prior to that, the head of the Jakarta Smart City in Jakarta provincial government. And he has been trained. In AHIN, we also talked about a variety of certifications and training. And he is somebody who holds the certification in TOGAF and then project management and also ITIL and COBIT. And he has received numerous awards, especially in the CIO category. And then he is driving the digital health implementation here, and then the strategy. I think some of you also attended the session on the digital health strategy yesterday, and he's driving the implementation. And we will have Dr. Chansali from Lao PDR. Dr. Chansali is the Deputy Director of Planning and Finance from the Ministry of Health. And he's also the Deputy Director for Health and Nutrition Service Access HANSA project, and then also the COVID-19 response project funded by the World Bank. And he's a medical doctor and then with master's degree in primary health care. And he has extensive experience in working with the government and then also the government-funded projects and World Bank-funded projects, especially on performance-based financing and then disbursement-linked indicator design and implementation. And with AHIN, he is also the working council member representing Lao PDR. And he has been working closely with us for the convergence workshops, which I mentioned about, and then also the implementation right now of the digital health strategy, which Lao PDR has developed. And now we will invite Dr. Gloria Nanita Velasco. We call her Dr. May. And she is also the working council member from Philippines, representing Philippines in the AHIN Working Council. And she is also a medical doctor. And her previous work experience was from the department concentrated on the bridging the gap between the evidence generation and public health practice. Currently, her efforts are concentrated on revamping the health statistical system and reviving and shaping the digital health work in the department, and her current designation is the officer in charge, the Director of Knowledge Management in Information Technology Service, and concurrently she's also the Director 3 of Epidemiology Bureau, Office of Health Statistics Systems Development of the Department of Health in Philippines. And then we have Dr. Palita Karunapema. He is the Director of Health Information from the Ministry of Health, Nutrition and Indigenous Services from Sri Lanka. He's also a doctor by training, and he has been involved with driving the digital health blueprint, which was developed by Sri Lanka, and then he's involved with the implementation. And he's also the member of COVID-19 IHR committee at WHO. And he is also our working council member. So we have 3 working council members representing Sri Lanka, Philippines, and Lao PDR in this panel. And as I said, this panel is on the theme of the event of putting the blueprints to practice, because yesterday I also heard in one of the sessions from WHO, and then also the one with digital health strategy, that having a goal without a plan is just a wish. And then here we are talking about taking the blueprints to practice rather than keeping it in a paper or a PDF. And I hand over the floor to now our moderator, Professor Alan Labrick, to give you a quick overview of the WHO's expectations on the blueprints, and it gets started. Thank you. Over to you, Alan.
We're eager to get started. Good morning. Good morning. Good morning. Hey! So it's really such a pleasure to be here, and I know the sound is a bit cavernous in this grand hall, so I'll try to speak clearly that everyone can hear me. But you know, friends and excellencies, if there are any excellencies left in the room, but most importantly, dear cyber geeks, I think we're among family, as they said many times today. Yesterday was an exhilarating -1 day, because today's our first day. We started early and we ended late. There were amazing discussions. We had some great side sessions and hallway conversations, the kind you can really only have at meetings like AHIN. I wanted to just thank the organizers of the AHIN Secretariat once again for bringing together such an excellent mix of digital luminaries. I think it's really a fantastic group of people. And really thanks to all of you for the leadership that you bring to this field of digital health. We are all here, as the Gates Foundation likes to say, impatient optimists. Change is happening, and the pandemic has changed the way governments around the world think about digital health. We're moving from experimentation to transformation. So it's an opportunity for us to reimagine how we deliver public health, separated from the legacy of a paper-based analog era, which is when these systems many of them were actually designed. So I'm going to start with a slide that hopefully you all know very well, originating from one of our distinguished colleagues here, Sean Blaschke, who published this slide in a paper many, many years ago. But this was a wake-up call for many of us. This is the 2011 Uganda e-health moratorium, when the government said no more digital experiments until government is in the loop, where interoperability has been demonstrated and digital investments are aligned with Uganda's national health priorities. Does that sound familiar to anyone in the room? So this was a major tipping point to get all of us to think about foundations and standards and systematically investing in evidence-based solutions. This led to the launch in 2012 of the WHO ITU eHealth Strategy Toolkit, the 7 foundational building blocks on which blueprints are still being developed. It showed up yesterday in several great presentations that I was listening to from the audience. But it took a pandemic to issue another wake-up call. one from where we are called upon to learn from each other's successes, as this AHIN network has done for so many years successfully. But not just each other's successes, but each other's failures as well. Because unless we learn from our mistakes, we don't progress as an ecosystem. But the other important shift that this quote embodies is the shift from digital solutionism to digital transformation. And what this means is investing in foundations. We've heard this over and over again over the course of this last year. It means investing in the fertility of the soil in which digital seeds are planted so that they can flourish and grow, where these planted solutions can interconnect as part of an ecosystem, a rich ecosystem of solutions that are owned and operated and part of a local, vibrant ecosystem of entrepreneurs. And this ultimately moves us towards person-centered health. So it's time we update the 7 building blocks, right? I mean, 2012 is a long time ago in digital era. But there are several excellent models that dive into, for example, this one from IQVIA that talk about enabling policies, the infrastructure, the shared platforms and standards, and the key data and tools which form a robust ecosystem. This builds national capacity, resilience, and most importantly, for countries that are just starting on their digital journey, it builds resistance to shiny object syndrome that we are all very, very familiar with. There's a new roadmap embodied in the Digital Implementation and Investment Guide, which many of you here at AHIN were key participants in developing. This roadmap depicts a systematic process of national priority identifications, informing a strategy, a costed roadmap that drives an enterprise architecture, and then governance, leadership that is key to making sure that those applications can be fostered and succeed. As our TBI colleagues, the Tony Blair Institute colleagues yesterday showed, in studies that they presented yesterday, there are common elements of success that include good governance, enterprise architecture, and enabling policies as key foundations for success. And so as we hear from our distinguished panelists today, we'll be hearing about how each of their experiences have invested in those key ingredients. And there are exciting methods that you've just seen from Jai's keynote address, such as the convergence workshop approach, to develop these roadmaps and action plans. We, in the Global Initiative on Digital Health, launched by WHO and other partners earlier this year, are excited to adopt this convergence methodology as a foundation. When we heard yesterday that our hosts here in Indonesia are investing 8% of their health budget on digital foundations, this should serve as an inspiration to all of us across the globe for this important shift. And so we don't just do this simply for the sake of digital, but to increase efficiency, reduce costs, and prevent wasted effort, to respect people's time, to respect the time of patients, people, and the workforce who are trying to deliver health services, but ultimately to reduce inequity and to improve inclusion. Today we have a very exciting panel, by the end of which we'll have learned about the status of digital health blueprint implementation in India, Indonesia, Lao PDR, Sri Lanka, and the Philippines. And each speaker is truly a deep and recognized leader in their country and in the field of digital health. So we're privileged to have them here. And without any further delay, thank you for being here, and let's get the panel started. So why don't we start with India, and JS, if you can give us maybe a perspective on your experience. And I know you've been advising not just India, but many other countries in the region.
Yeah, thank you, Alain, and good morning, and thank you for giving me this opportunity to present my experience with the digital health journey in India. Yeah, so because this is the very first session and my first presentation, so I thought this word blueprint has been used several times in different contexts. So what I said, I will spend a minute on this and see. So digital health blueprint is really beyond strategy. It's an action plan to address the challenges. You start with the challenges of the the health sector, not digital health, but challenges of the health sector, health systems per se. Look at those challenges and see how, work backwards and see how digital can help in the process through an enterprise architecture, and more increasingly you call it ecosystem architecture, because it's not only the government, but it's a lot of things happen in the private sector and so on, NGO sector. So you need to have an ecosystem architecture to really move faster towards UHC and SDGs. So that is the essence of the blueprint. And then what does it contain typically? Before you spring or push it into action, really what does it contain? You can see why do we need it in a country's context or in the regional context and the global context? Why should you spend your time and effort and money on this? Is explained there. What's the value proposition end of the day to the various stakeholders? The what is the most important part of the thing. It is really, we are blind most often to the what part of it. To the result that how and when, etc., gets delayed and confused. So what is really a set of objectives and principles and so on, and let us leave it to fate. Third one is how. So it's a question of why, what, and how is contained in the blueprint. So as you, of course, blacked out, it says that the strategy which Alain showed us in his initial remarks to blueprint to action. So we are in that last journey there, blueprint to action. So can you please remove the blackout, please? If you reboot it or something, the team there. It's really annoying. Is there? Oh, there, it's all right. Is a problem? Okay, I'll go ahead with as if there are two screens which are good. One is blacked out. So it's quite. Yeah. I can stand here and probably. So as this alignment of the investments into IT that go in the right direction to meet those challenges. And also one key thing is the person-centric nature that we have to canvas for going forward on this versus the institution provider-centric systems which prevailed in the last 3-4 decades in several countries. And also the minister also was very rightly emphasizing the need for interoperability, as in the case of the financial sector, banking sector. Can you get a similar thing into? So this is the purpose. One of the key objectives is the interoperability, and then governance and the digital ecosystems. Now in India, you can see that the journey started somewhere in 2018, and when the national planning body created the initial document, and then we went on to create the National Digital Health Blueprint, of which I was privileged to be the chairman of the committee that prepared the blueprint in India. And then other stages, currently a digital mission was launched in 2021, and you see the result of that. The key thing is the institution of as a dedicated organization which will push it, yeah. So in addition, the minister also, I heard him say a word about the sandbox, which brings all the innovative solutions together, validates them and pushes into the ecosystem. So these are the steps through which we went. And what did we achieve in these 4 years in India? Put all these building blocks. It's like, a Lego game where you take a number of building blocks, you create the building blocks, and with the help of the building blocks, different combinations of those building blocks, you really build different structures. Here it's different digital services through these building blocks. which is like an email account. So it's online, and then go forward with it. And then second is you can see that in the span of about last 2 years, where it is more active, 482 million health IDs have been created voluntarily by the citizens of India, which is more than 30% achieved with a population of 1.4 billion. In about 2 years, 482 million health records have been created. So that's the key to the further, availing all the services using this unique health ID. And second one is the health professional registry. All the professionals, the doctors, the specialists, and others, 240,000 of them, because at the end of the day, you need to identify who is providing the service to the patient. Then you have the facilities registry, which are all the health facilities, primary, secondary, tertiary level, that are providing these services or will be providing these services. So to identify them uniquely and etc., and see what the infrastructure they have, it's a facility registry has been created with 223,000 facilities already onboarded. And the key thing here is about the interoperability. The minister also, in the very opening sentence, he mentioned UPI, Unified Payments Interface in the banking sector. So equivalent, exact one-to-one equivalent of that in the health sector in India is the UHI, Unified Health Interface, which is a set of APIs put together, protocols, which enable these services to be made, in a very efficient manner. So currently 5 services are launched in that, as you can see on the right side. So it's operational, in a big way. Then the last one is, end of the day, I mentioned that it's citizen-centric. So how does that citizen-centricity come? Through creation of those records for each citizen. The citizen is the boss there. Citizen is in control and in charge of his own or her own health record. It happens through the PHR, or personal health record. India, you can see in this year plus, we created 320 million PHRs. We, meaning we, the citizens of India, individually, no institution has created. The individuals of their own volition, they created 320 million. So it's a person centricity is reflected here. Of course, the potential is billion plus with a population of 1.4 billion. We are somewhere at 10% or maybe 5% of the records created so far. But this is an impressive beginning for the first year and a half to say. Lastly, in my last slide, what does it take? What are the challenges? What does it take to really make such a multi-million, people impact that you have seen just now? So on the left is the set of catalysts, dedicated institution with which I started, as a mission, with a missionary zeal. It has to, a small team, 30, 50 members, depending on the size of the country. Then the federated architecture, which means that you're not accumulating all the records at one place. You are allowing the records to stay where they are with the various institutions, and then access those records on a need basis through consent. Person-centric systems, which I already explained in the previous slide, through PHRs. And the key thing is about consent. How do you manage the consent, which is very, very important? You can't just be sharing records as open records. They are under the control of the citizen. Through consent only, another can see it. Then trust, and then enabling rather than building. The previous one is very important. Don't try to, as government, to build everything. Only the core things the government should do. That's what we have done in India, and enable the rest to happen through the private and NGO sectors. And on the right is a mega plan. You've seen Jay Ganesh speak about 4 gaps: governance, architecture, programs, and standards. So I have been, as hinted by Elaine, I've been working on the blueprints of several countries, including Maldives, which is present here, and Bangladesh, which is also present here, and other countries. So the pattern that is emerging is there is a core in the middle, and then there are 4 nodes which take care of these 4, roughly equivalent to the gaps, GAPS, that has been mentioned. On the one side, you have community health. I will not go into details for want of time. You can review this later. The four nodes, one deals with the community health, population health, public health, by different names you call in different countries. So what are the various elements or various services that are required? It's a hub and spoke, as you can see. On the other side, you have the individual health, a person's health, and all the requirements of a person. And the third is information, HMIS platforms, I call it as such. And so the entire program management, the P part of it there in Jay's presentation. Finally, the human element that really drives the whole thing, the professionals, the field workers who do that, one segment for them. So this is the kind of pattern that is emerging, but the most important thing which the government should focus is the core in the middle, which is the health, UHID, unique health ID for each citizen, and an information exchange which is standards-based, and a set of registries which I have shown before. So this is the kind of pattern that is emerging. Probably with a little bit of consultation, we can standardize it, make it an open architecture for all the countries to adopt. So with this, I thank the organizers and welcome for any further clarification on this. Thank you.
Setyaji, if you would like to present the Indonesia scenario.
Yeah. Okay. Yeah, I think my minister already delivered well, my slide. No, I will give some slide.
In the next few decades, health services will be significantly transformed. Medical treatment is getting more precise by looking at the patient's genetics, lifestyle, and environment. Smartwatch as wearable devices will help us and help workers to monitor health conditions as well as detect emergency situations for immediate response. Patients can access their medical record via mobile phones. This is the time for the technology transformation. Health technology transformation is the sixth pillar of the Ministry of Health's Health Transformation Agenda. Starts with the development of a platform as a service named Satu Sehat, which will integrate all health technology systems in a standardized format using the global FHIR standard. Primary, secondary, and private healthcare facility integration. This is the health data interoperability proof through the Satu Sehat platform. The integrated data will easily be accessed by patients and health facilities based on the patient's consent. Health transformation, Satu Sehat.
Maybe we still remember 2.5 years ago when COVID came. Actually, this is like an alarm or wake-up call for us. We have some issue, not only about our health system is very fragile. We have some lack for health facility, the numbers, and also the doctors' numbers, the specialists, the drugs availability, and many things, and also about the health data. We have some struggle to get the collecting the data real time. We have some delay input for the data. Because of that, it's very important thing. Actually, after or during the COVID, this is a wake-up call for us. So we set up the digital team to accelerate the initiative or digital transformation in Indonesia. And then we learned a lot from the COVID-19. Not only how we need to build the special team like DTO, and then we need to also to build what we call this digital health strategies. And then we also built the platform. Actually, the platform itself only for the COVID-19. And then the important thing, we need collaborations. Because of that, the end of 2021, we delivered, launched the blueprints during the COVID. So I think my hand not only two during the COVID, because we need to fight the COVID and then also develop the blueprint, because it's very important thing to give the strategies and also publish to the citizens, all the stakeholders, to inform this is our journey, and then this is what's the standard we use to make sure all the people or all the stakeholders can align with us. Yeah, in our target is we have a 3 agenda. First, how we need to integrate it, all the data coming from the 60 health facility. Yeah, we have to about the data itself is very different between the health facility. And then we need also to make simplification. As you know, we have more than 400 applications. It's very struggle for the health facility to input many applications in every health facility. So we move our approach. No need to build the application just for report, and then we transform into the application just only for services. Because of that, we reduce more than 400 applications into the 8. Actually, this is like we built like the killer apps for all the industry. And then the important thing, we built the health innovation ecosystem, because the government cannot run alone. Because of that, we built a platform, and then all the health facility, all the startup can together with us build the application, etc. How we can move fast? Because actually we no need to integrate it to all the 60,000 health facility. We just need to connect with maybe around 500 vendors, because they work with us. They work to me to facilitate the digitalization in 8 health facility. I think this is the smart way to connect to all the 60,000 health facility. Just connect with the 500 until 1,000 vendors. Yeah, this is our journey. So we built the platform. Actually, the platform itself is coming from COVID apps. And then we built the data exchange protocols. Actually, we not built by own. We just use already there in a cloud. And then also simplification the applications. Yeah, this is the Satu Sehat platform. We'll connect not only the health facility, more than 60,000, and then also we connect the health services in outside the building, because not only activity in health in building, but also in outside building. For example, like Posyandu. Posyandu is community centers, and also to get the data, to collect data coming from the home services, and also we connect with the citizens. For example, like smart devices, and also IoT, and etc. To make sure all the data can capture from the baby till the end. And then also we connect with the health industry. For example, like startup, telemedicine, insurance company. So we want to build what we call the health index for every patient to make sure the primary correct with us. And then the important thing is the people can access their data, because before the patient cannot get the data. The data is belong from the health facility. Because of that, we built this awareness for the people. This is your data. So this is your right to get the data from directly from the hospital. And then the doctors can access their data coming from different health facility. And then the important thing is about the data itself. So after the data collecting to the national level, so we'll deliver also into the regional level. So the regional level can access the same data coming from the regional and also in the central governments. This is the near real-time data coming through for this system. Yeah, this is some glance of our research during the COVID. So we have the COVID apps. Actually, this is the most or the biggest application in the world for the COVID app. More than 105 million people downloaded this. I think some of delegates from here during the COVID when they arrived in Indonesia already downloaded it. And then we still use this application. We transform into the Satu Sehat mobile to beyond the COVID. Yeah, and then we also built the application to improve the telemedicine using the Satu Sehat. Yeah, and then this is the result after the COVID. So beside Satu Sehat, before the Peduli Lindungi, we transform into the Satu Sehat mobile. Now, more than 11 million already download with the Satu Sehat. And then also we connect. Last year, we have some roadshow to the West Java, all the Java Islands, and then more than 10,000 already connect with us, and then send daily data more than 1,000. And then also we built what we call this, the second sandbox regulation in Indonesia after the fintech company to make sure the innovation still can grow, and then to make sure the system also comply with us. And then this is the result coming from the outside of buildings. So we already registered more than 100 million individual immunization record for baby. Yeah, this is a very big data. And then also we run the genomic, I think my minister already mentioned. And then also we use like a WhatsApp to deliver some notification to all the mother cares after they waiting the baby, and then they got information or data. Yeah, also we send the result for the USG, the image. It's coming from the health primary cares. And then we send to the baby, oh, this is your USG, oh, your baby is a man or boy or girl, they can get the data. And then the last is the data, our data. Our data is actually is open for public, but only for aggregate. And then we open for the private data to the regional facility. Yeah, more than 100 million patient data were recorded using this data. After this, so my minister only view the data from their mobile using this data. Yeah, I think this is, and then the last thing is about the challenges. Actually, we have some issue not only about the regulation, about the policy, about the reluctance for health facility. Because of that, we deliver the team for acceleration to make sure it can accelerate more fast. As you know, we have some issue of I think no hacking from us. Yeah, okay. And then also we finished to deliver the new bill to mandate all the health facility to integrate it with us. If not, my minister will take out your accreditation. Yeah. And then the other thing is support from Ministry of ICT, because as you know, in Indonesia have many area not have internet access. So now we have the satellite to give you internet in the rural area. Yeah, I think this is our journey, because my minister have a strong leadership and also collaboration within all the health industry in Indonesia. And the important thing, we have the 235 dedicated young guns. This is like arsenal young guns. Yeah. I think this is the last slide. Thank you.
So with that, let me invite our guest from Lao PDR.
So thank you, Chai, for introduction. Also, Professor Alan, for really good introduction to the topic of the putting blueprint into practice. So for Lao PDR, maybe different from other countries, because different level of development of digital health in our country based on the Lao. Maybe different from Indonesia or other countries, because yesterday when we have the session yesterday, we see a lot of very comprehensive strategy, digital strategy presented by Indonesia and other countries. For Lao, maybe different. different because we are very simple, because we have only 7 million, the country. So actually, the digital health has been already started 10 years ago. We apply the DSS2 as the main platform to collect, to report, to analyze, and to present and to disseminate information on the health information, and also for decision maker to report on the progress of health program in our country. So by that time, we think that we are happy about it, that we have a platform to monitor the progress of health sector in Lao PDR. However, when we came to attend many meetings, meeting, look health in more broader. So we have like an introduction this morning that we are moving from paper-based to the electronic. Is not enough. So we have to link different part of the information together. Lao is, if we're talking about digital development, it's just really initiative. It's not like Indonesia, like the Philippines, or in India. It's different. We're just starting. As an introduction this morning, that why we have to moving to the electronic digital strategy, because as you know, like in our country, we have parallel development. Aside from DSS2, we also have different platform happening in the country, like electronic medical hospital information system, the lab information system, the human resource, the M supply, which is silo. They are not linking to each other. We know that when we go to the hospital, the staff enter the data in different platforms. They are not linking. So that's why we develop this better. We could have a strategy that all people can follow. So we have gone to different stages for the development of the national digital health strategy. So we gone to the civil and conversion workshop. As I mentioned this morning, that Chai mentioned, we have 2 workshops in Lao. One, if we present the concept of the gap to people, because the gap is very new to the country. What is the governance? What is the architecture? What is the people? What is standard? So when we present that, many people step by step they understand, and then so the second conversion we conduct again, and this time we go in deep every component of the gap introduced by the Ahin. I remember that Dr. Arvin also present online also, because at that time 2021 still people cannot move around, and we mainly present in the virtual meeting. However, we gather all the stakeholders, meaning that not only the government, but also other ministry, like the Ministry of Technology and Communication, MOHA, and other ministry are also joining National Statistics Center. So we agree that, okay, we need to find the way how we can putting all together in one strategy that we can moving forward to the digital system in Laos. So, so this one, the process that we have gone through, and in this main conversion workshop, we also talking about the ID system. We also talking about the how we can link between the current EMR, meaning the hospital information system that has been now developed in many hospitals in different software, different approach to how we can link this one. After that, we have also follow-up, because follow-up meeting. So because of the result of the conversion give us a lot of activity, a lot of project or program based on this four main concept of the AHIN. So, and then we organize that we can see that we need to select, we need to prioritize which we are going to implement first. And then we have several consultative meeting, we call the technical working group, so that we involve very key department, very key ministry to gather. We're starting from forming the vision of the strategy, and then back. So this is the main strategy that we putting together. It's really simple. That it's not sophisticated like other strategy. We have identified the 5 strategic priority, 16 strategic objective, 37 strategic project, and 122. So meaning it's very specific. If anyone can took this strategy and it can be implement the activity. If you counting that all the things will be name of the project, name of the strategic, and we had to go down into the detail of the strategy. In the strategy, will be in putting which one we are going to do first, to do now, which one we are going to do later, which one will be later on. And we also put all the roughly costing on each project and activity, so that any partner want to assist or implement. Now, the strategy has already been start to implement, because the strategy has been approved by the Ministry of Health since the end of 2022, and we already start implement this strategy already nearly 11 months. So we start, because according to the strategy, we are weak on the workforce, so we start already training of the staff on this digital concept. And also we introduce some of the curriculum for the medical college, so that they can teach also the digital concept in the university. And we also engage with different partners like ADB, like a World Bank, and also Global Fund to support the implementation. Now they already commit to support the implementation of this strategy. We think that we will by the end, because this strategy is starting from 2023, 2027, 5 years. So hopefully we can implement this strategy in the near future. So, as I said, this is progress of them have been done, working with different partners to implement this strategy. So this is the organization governance, how we can putting this strategy into practice. So we already have different department. We need to set up the digital health coordination office. We have, but the thing is that we have really strong government support, because now the government implementing because digital transformation to all sectors is starting from the Prime Minister office, and we have already decree, have already regulation to inform all ministry in Laos, not only health sector, to transform from the digital transformation all activity in Laos, so including health sector. So now we already having the structure, but the challenging is that because we need to set up the digital health strategy coordination in the Ministry of Health. We need to set up the steering committee for the digital strategy implementation in order to report to the government on the progress of the digital implementation in Laos. So I think that's it for my presentation. Thank you.
So we're seeing quite a large landscape of different experiences and challenges from different perspectives. With that, I'm inviting our colleague from Philippines.
Good morning, everyone. Actually, it's already afternoon. I'll really try to keep this as brief and as focused in consideration of our time limitations. But for us, and actually found it very interesting how the different countries have actually defined their blueprints. But for us in the Philippines, our national digital health blueprint is our health sector enterprise architecture. So the past months, we've actually initiated work on this, on our EA, specifically covering the period of 2023 to 2035. And for us, that blueprint really represents the architecture of our information systems that we are intending to use within the health sector. And for us, very important, because within such a complex system, it's really important we have that blueprint to guide us, both in development and management of these systems. So for our purposes, we want our architecture to help us rationalize, streamline, integrate, and implement various operating models for the sector's major business processes, priorities and strategies, data services and applications, resources, and information technology needs and capabilities. So for us, very important that our architecture helps us inform the growth of future technologies within the entire Philippines, and also help us, I suppose the word is control, but I think for us, better manage the development of these technologies. So very simply, we were asked why or what is the primary reason for the Philippines in deciding to develop a national digital health blueprint. There is quite a bit of content on this slide, but there are two distinct periods in time actually for which, like, what was the impetus for us to develop a national digital health blueprint. And that is fundamentally our medium-term health sector agenda. These are aligned with both global and national development goals, such as the SDGs and even our Philippine Development Plan. But for us in 2011 and for now, 2023, driven by the Aquino Health Agenda in 2011 and then now our 8-point action agenda. So from our very first experience with setting an enterprise architecture back in 2011 and then now in 2023, it's evolved quite a bit. So in 2011, we set the vision for the enterprise architecture, whereas in 2023, the intention is really to transform business processes. So in 2011, our EA actually supported activities towards a refocused national insurer, or that's our PhilHealth, our Philippine Health Insurance Corporation. It helped us upgrade our health facility strategy and contributed towards the attainment of MDGs 4 to 6. So within this enterprise architecture, we are able to identify 9 guiding principles that focus on the foundations actually of EA development. And our entire architecture itself articulated the vision and described the 15 foci. Whereas our enterprise architecture, which is our second iteration in the Philippines, as I mentioned, covering the period 2023 to 2035, it really focused on our Universal Healthcare Act of 2019, the transition from COVID, and our 8-point action agenda, which is the health sector's policy agenda. And I already mentioned what it was intended to support. And basically, within this enterprise architecture, we've reflected or updated 4 of the existing guiding principles, focusing, as I mentioned earlier, business process transformation. And we've additionally described core and enabling capabilities of the architecture and identified 33 key performance indicators. So just very quickly, our methodology. So we've been working very closely, actually, with CNAG Solutions, if Francis is here as well. Thank you to him. But really, we started with, of course, developing, what would actually be included within the terms of reference of that particular work. We initially started out as a project. I think directionally where we want to take it is really institutionalize the use of the enterprise architecture approach within the department. So from there, again, also choosing TOGAF as the de facto industry standard in EA development. I mentioned already CNAG Solutions. We've actually used their simplified EA methodology. And I think the latter 3 boxes are probably the most important. Yeah, so very important that we're able to secure buy-in from high-level department leadership. That includes our undersecretary and, of course, our office, being the IT office of the department. And then from there, we actually able to collect artifacts from 28 DOH offices, bureaus, services, units, and conducted 50 interviews. And in addition, and as I mentioned earlier about institutionalizing EA within the Department of Health, is in the introduction of TOGAF and Archimate as well. And I think to really foster the use of EA within our department, we've actually created an EA community of practice, or our Digital Futures Group, and starting off with the 28 individuals that actually helped us in identifying the artifacts. And those included participants from different offices, bureaus, services, and units within the department. So, how did we translate our digital health blueprint into practice? I think Indonesia and India actually showed excellent examples of how this has been already put into practice. But I think for us, a few things that we've done so far is developed our long-term EA policy or plans, and this includes mapping business processes, will also include mapping business processes for regional provincial health offices. So we've started mainly at the central office, but we are looking to extend the work most certainly to our more subnational units. And I think within the context of universal healthcare, looking to develop enterprise architectures likewise for our province and citywide health systems and our healthcare provider networks. We have also been able to identify 8 key programs which focus on technology or solutions development to support the country's health sector strategy, or the 8-point action agenda that I mentioned earlier. And then lastly, we've already started initiatives to streamline information systems in the department. We currently have more than 200 systems, and that with the aim of eliminating redundancies and reducing the agency's operational and maintenance costs. So one additional practice that we will already be applying, the enterprise architecture, is in a more recent activity in which we identified two solutions with potential redundancy. So that is related to our immunization information system and a mobile application for which is currently being developed to assist data collection on the field. And our last slide is actually on the question is how did the Philippines translate the blueprint development into actual action or implementation, and to describe a few of the governance mechanisms. So first, our enterprise architecture served as input in the development of the digital health strategy of the Philippines for 2023 to 2035. There will be an expert group on the health enterprise architecture that will be lodged under our broader digital health governance structure, and this will be formed actually within this month. And we've also drafted a policy on the adoption of the health enterprise architecture, and another policy on information system ownership, which is geared towards a more client-centric digital health solutions development, and this is pending approval within our department. And lastly, that we've initiated that EA mindset within the department, as I mentioned earlier, through a community of practice, or the DFG, within 28, with our participants from 28 operating units within the central office. And we intend actually to grow that community of practice, not just within the department, but most certainly outside, and to involve more stakeholders from the health sector. So with that, thank you very much.
Last but not least, we have our colleague from Sri Lanka, if you would like to give us their examples.
Good morning to all of you. Yeah, we have seen different countries present in the different types of blueprints and different stage of maturity. First of all, I would like to say we are in the very early stage in implementation of the blueprint. Our blueprint is actually initiated in 2019, basically based on the health master plan and the national health policy and the strategic framework, which was developed in 2017. Now, when we actually developed this blueprint, the purpose was there were many digital health systems available at that time and right now, but there were digital health challenges we face, especially to interoperable the data between different systems. So that's the key point, And we want to see the future state of these digital health systems. So that's the whole idea of developing the digital health architecture blueprint for the Ministry of Health. Then actually the goal is to initiate this development to interconnect the individual level data from different systems. And there are few hospital-based information system EMR. So that was the kind of a prime objective, is to develop this system. And the whole idea of this blueprint is to provide the efficient health systems to the patients. Not really digitalizing everything, but the purpose is to provide a universal health coverage and provide the efficient health system to the patients. And also this blueprint provide the enterprise solution and technical views for the vendors, for the developers, in order to develop these different software applications. The last version of the blueprint, the version 1, actually we published in this year, 2023. And I will just give a very brief development history. In 2019, it was initiated by the Ministry of Health with the participation of especially with the health informatician. In Sri Lanka, we have doctors who specialize in health informatics, so they initiated this process, but it was delayed in 2020 and 2021 due to the COVID pandemic. And then we completed the zero draft in 2021, and then as a part of the Debt to Health grant by the German government through a global fund, we initiated this process again in 2022 and completed in 2023. Right. This is actually the Ministry of Health initiative, even though it is funded by the German government and with the support from the government digital health agency. So it really linked or in line with the government digital health policies. So it's again, initiated with the appointment of core team led by the Ministry of Health. And first we did the stakeholder mapping, and there were many consultations with different stakeholders within the ministry and outside partners. Then we have very rapid development phase of different cycles of the document. And many reviews were done, and especially probably when you're developing this blueprint, the first challenge is to convince that this is really important for the Ministry of Health. This is a real challenge. I think Bhutan also mentioned, Lao PDR also mentioned this. So it's a challenging thing at initial stage. So then we got the endorsement of global partners, development partners. This is really important, probably in the later stage. And we also present this to the government and parliamentary committees, so to get the high-level buy-in. Then basically translate into the practice or actions, the key lessons we learn, it is really important to engagement of the partners for the implementation. So it's a diverse stakeholders are there, so getting to the realize the importance of blueprint is really, really important. Then strong advocacy is needed to get the support from high-level ministry officials and high-level other government agencies. And when you talk about the blueprint, it is it cannot implement without other components of the digital health building blocks. So need to have a high-level capacity, institutional capacity. Then the procurement plan and procurement funding is required. Then we also now we are developing the governance plan. AHN also supporting this process. And we also concurrently developing disaster recovery and data security plans. Then basically catalyst for the actions, advocacy is needed at even when you once you develop the plan, it is really important to rolling out, realization. Realization also require strong advocacy. At this stage, we are at the various early stage of implementation of the blueprint. So first, last year we started developing the Sri Lankan fire profiles. Then currently we are developing the prototype of National Digital Health Platform and the data exchange. Now these are the real technical things which we probably support even through collaborations from AHN and some other partners. Then we had now in last few months we were able to do some initial work on integration of different EMR vendors. Development of National Electronic Health Record and Patient Portal. So basically we done the blueprint first version, and we are in the very early stage of implementation of the blueprint. Thank you. These are our partners, and we need to acknowledge German government, Global Fund, WHO, ICTA, College of Health Informatics, these international partners, eShift, and the Minister of Health, all the partners. Thank you.
I just want to say thank you to a really distinguished panel. I know we're running a little bit over time. It wouldn't be a digital health panel if we didn't have a good dose of technical challenges. So I think for your resilience in pushing through, each of you had technical glitches. So maybe we give a round of applause to the panelists for just doing such an exceptional job. But it's a good reflection on how we all need to reflect adaptability and resilience in the work that we're talking about in digital health. Clearly, there is one silver lining of the pandemic, and that has been providing a wind in the sails of these initiatives across the board. For lack of time, what I will try to do is recapitulate maybe 5 key takeaways that I heard from each of your presentations. Clearly, there's a need to invest time and effort into these activities, and they require sustained investments over time in order to realize. The 5 elements that I heard from each country in common, spanning Sri Lanka, Philippines, Lao PDR, Indonesia, and India. One is a clear vision of where to go and why we are going there. Communicating the value to stakeholders is absolutely critical to get buy-in from every level, including the most senior leadership, because this is a shared journey. I heard several of you mention this. The second point was strong governance, clear policy, and leadership. So making sure that there's leadership in place and governance to see this moving forward, including in the shape of regulatory sandboxes to allow people to test their solutions, but also focused agencies who have the mandate and the capacity to see through this journey. The third was digital public infrastructure. So making sure we're investing in digital public infrastructure, including canonical registries. Each of you presented a set of registries that were being supported and maintained by government, including a health information exchange and a universal ID of some sort, whether it's a health ID or a national ID. Fourth was federated architecture and clear public and private sector value propositions. So being able to bridge that gap between the private sector and the public sector through incentives. And I think here is where both the minister this morning iterated this concept of there needs to be carrots to entice people into the game, but there also have to be some sticks. And so I think as government, it's the responsibility to ensure that the carrots are there, but the sticks are also there to maximize engagement. And then last but not least, each of you mentioned the importance of keeping people in the focus, right? The benefits, the experience of the end users and the public, but most importantly, getting consent and building trust. And so it's fantastic that across different levels of readiness, different levels of maturity, we came away with really some very common elements that underlie each of the strategies that are underway. So with that, I want to thank the audience for being so patient and coming with us on this journey across 5 countries. But more importantly, thank you to the panelists for your insights, and good luck on these pathways ahead. Thank you all very much, and have a great morning.